We are on live, sir. We are good to go now.
Okay, thank you. Sir, चालू करता हूँ हाँ?
Yes,
Start कर.
yes.
While I'm starting, huh?
Yes, sir.
Hello, doctors. Good evening. Welcome to this online webinar on the role of oseltamivir in flu management. This webinar is brought to you by Heathrow Healthcare, an innovative pharmaceutical company. Heathrow Healthcare, the journey began in 1993 with 30 years of excellence and 36 state-of-art manufacturing facilities. Heathrow Healthcare has 300 plus products in portfolio and presence in 126 plus countries. With 21,000 employees globally, Heathrow Healthcare is the largest closely held pharmaceutical company in India. It is among the largest manufacturers of ARV, APIs, and FDFs in the world, and Heathrow Healthcare is Asia's largest API manufacturing facility at SCZ Complex, Visakhapatnam, Andhra Pradesh. Heathrow Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. Heathrow Healthcare pioneers in quality and innovation and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Heathrow Healthcare, the pioneers in antivirals, offered Oseltamivir, Favipiravir, and Remdesivir to the patient, because of which, in August 2020, Heathrow Healthcare received an award of Pharma Excellence for COVID drugs. Today's webinar, Role of Oseltamivir in Flu Management, we have got Dr. Shailesh Chandra as our moderator. Welcome, Dr. Shailesh Chandra. Dr. Shailesh Chandra is MBBS MD in Pediatrics. Sir is Senior Consultant Pediatrician working at Rani Hospital, Ranchi. Sir has more than 20 years of experience and Sir is a DNB guide. This brief introduction, I hand over the session to Dr. Shailesh Chandra. Over to you, sir.
Thank you, Prashant sir, and thank you, Hetero Healthcare, to giving me this opportunity to talk on this topic, empiric use of oseltamivir in flu management. So we are using oseltamivir.
Sir has logged off, I suppose.
I think he's facing some internet connectivity issue. Let me connect with him.
Yeah.
Okay, sir, I was. Can you hear me? Hello.
Yeah, we can hear you, sir.
That was technical problem.
No problem, sir. No problem.
So can I get the back slide, one slide back? Yes. So the today webinar will run through this headings: healthcare challenges in monsoon and their diagnosis. We know the flu is a monsoon disease, and brief microbiology of the influenza, and in brief also the complications of flu. Then there are evidence of oseltamivir in pediatric practice. Then the guidelines recommendation for empiric use of oseltamivir. Next slide. So in this cartoon, we can see the various flu virus, influenza viruses, or there is a monsoon disease. One is influenza-like illness. And among influenza-like illness, there is a H1N1 also. And in severe cases, may develop acute respiratory illness and COVID-19 is also an RNA virus. So these are the monsoon diseases. So now COVID-19 means this COVID virus is less found, but we remember the COVID days. Next slide. So in this slide, we can see the number of case and death in 6-year duration. That is taken from the Purple Book of Immunization. We can see the number of cases in 2017 was 38,000 and death was around 2,000. So there's a high rate of mortality, and this is particular to the H1N1 influenza disease. Likewise, rough data from 2018, 19, 2020 as well. There you can see the less number in 2021 because of the COVID. There are less interaction among the people. And as the COVID period gone, the relaxation phase begin. Again, there is a rise in cases of influenza. So it's not off COVID time, we can expect very good number of influenza in our practice. And likely wise chances of death also. Next slide. The same thing have been again shown by the cartoon in the form of bar diagram. You can see the left side is the cases and by right side is the number of deaths. So high number of cases brings high mortality. So when influenza incidence is related with death and is very alarming in our population. Next slide. So brief about the microbiology. We have know that influenza and RNA disease, and it's characterized in A, B, and C. And A is most common frequent cause of epidemics due to the major antigenic variation, and sometimes pandemic, which is due to the major antigenic. So it is influenza is an endemic disease, and it is found in it also have some seasonal variations. Influenza B infects only humans and causes global epidemics. The two strain is available, Yamagata and one other strain. Influenza C virus infects humans and swine. Influenza type C infection generally cause a mild respiratory illness and are not thought to cause epidemics. So currently circulating human serotypes are H1N1 among A and S3N2 also from the influenza A virus. Next slide. So we know that transmission of flu virus happens with droplets, which are generated when people cough, sneeze, or talk. So these droplets may either land in the mouths or nose of people who are standing nearby or possibly be inhaled into the lungs. People should stay away from the affected person and stay home if sick. It is also important to wash hands often with soap and water to clean our hand from droplets. So mostly healthy adults may be able to infect other people beginning 1 day before symptoms develop and up to 5 to 7 days after becoming sick. So children may pass the virus for longer than 7 days. So not only during the infection, after the infection, children may pass viruses to others. Next. In this slide, we can see the symptom differentiation with influenza-like illness, H1N1, severe acute respiratory illness, and COVID-19. The major symptoms are fever, which is found in all the four, myalgia, body ache, cough, lack of energy, sore throat. These symptoms are common, but breathlessness is more in H1N1, SARI, and COVID-19. And the important finding is loss of smell and taste in COVID-19. And other system involvement is also found in COVID-19, the diarrhea and sometimes headache. So this table makes us to differentiate among the 4 common monsoon illness. Next slide. And further talking about the warning signs of influenza illness in children, if influenza gets complicated, may develop fast breathing or difficulty in breathing, then cyanosis. And because of fast breathing, child may not be able to drink enough fluids, not become lethargic, and not interact with others. Sometimes become irritable that the child does not want to be in the lap of caretaker, and flu-like symptoms improve but then return with fever and worse, cough worsens. Sometimes there is a rash also. But in adults, beside cough, there is shortness of breath. They feel difficulty in breathing, and also the chest pain out of proportion to the breathing, then feeling weakness, feeling confusion, and sometimes severe or persistent vomiting, and flu-like symptoms that improve, then return with fever and worsen with cough. So in addition to the signs above, get medical help right away for any infant who has any of these signs. So for severity of the illness, we know they're manifested by unable to eat, as fast breathing, as no tears while crying, means child is dehydrated, and dehydration. Other sign of dehydration is decrease in number of wet diapers that happens to be usually. So sickness is assessed by clinically by the fast breathing and decrease urine also with the children who do not use diapers. But in adult, the sickness is assessed by body ache and particularly the chest pain and shortness of breath. Next slide. These are the in brief or the complications of flu. You know, you can see this green color and orange color, and this the most severe is death. Milder form is pneumonia, viral pneumonia. In children's bronchiolitis, sometimes in ear infection also may there. In adults, there is worsening of asthma or chronic obstructive pulmonary disease. In severe cases, may develop ARDS and sometimes death. Next slide. So knowing the epidemiology and complications and the microbiology, we move forward to treatment of influenza. So we know it's a viral disease and the treatment is largely supportive. It includes increased fluid consumption, home rest, sometimes cough suppressants, and round-the-clock paracetamol as analgesic as well as antipyretic. In severe cases, some non-steroidal anti-inflammatory drugs may be also used for the myalgia. So most patients recover in 3 days. However, malaise may persist for many days. And severe cases may require some intravenous fluids and other supportive measures like oxygen and regular intense monitoring to monitor the worsening. So treatments in category A and B and C when the complications are severe one. Slide. So influenza is one of the disease where we have antivirals. The antivirals are of 2 groups for the influenza. One is neuraminidase inhibitors, which blocks the viral neuraminidase enzyme which is critical in releasing virions from the infected host cells. And these drugs are active against influenza A and B. Example are Oseltamivir and Chanamivir. Adamantinones, these are M2 ion channel blockers. They interfere with hydrogen ion channel activity of the influenza A virus, thus blocking its entry into the host cells. Active only against influenza A virus. Example are amantadine and rimatriptyline. Next. So amantadine is not affects influenza B. So we have left with only one option is oseltamivir. We have just told that it is oseltamivir is inhibitor of the neuraminidase enzyme of the influenza virus A and B. Oseltamivir is a prodrug which is converted into the active form. Oseltamivir carboxylate in the liver inhibits influenza virus replication and pathogenicity, prevents further spread of infection. It is effective against all strains of influenza A and B, including avian H5N1, swine flu H1N1, and H9N2 strains. Next slide. The same have been explained by this cartoon. You can see this spoke-like structure is virus. When we come in contact with the human cell or any cell, that virus attached to the cell membrane of the host and then releases its DNA. So the DNA when released by the neuraminidase, and then they multiply and formation of new viruses occurs. And these are the, you can see this with the, you can see that neuraminidase inhibitor, when we use this oseltamivir, this neuraminidase is inhibited and there is viral replication is stopped. So there is no release of new viruses. So thus, if used early, oseltamivir will not only decrease the symptom also, this also will spread to the others also. So it has also herd benefit. Next slide. So oseltamivir is the first oral neuraminidase inhibitor, and as told in discussion, that is approved in more than 100 countries and also approved by the FDA and Center for Disease Control and Prevention, USA, as well as American Academy of Pediatrics. Next slide. So this is the brief detailed chart of oseltamivir doses. In pediatric adults, it's a 75 milligram capsule and given twice daily. And for treatment, you can see this first column is for the group and second column is for the treatment and third column is for the chemoprophylaxis and fourth column is the how we can give the suspension. So suspension form is available as 25 milligram, 12 milligram per ml and capsule is 75 milligram capsule. So for less than 15 kg, for the for treatment and chemoprophylaxis is dose is different and duration is also different. So it is important to note that in 15 kg, the treatment is 60 milligram per day. That is 30 milligram 2 times a day. And the same 30 milligram once daily for 10 days becomes chemoprophylaxis. So for the treatment is 5 days and for chemoprophylaxis is 10 days because the incubation period is 7 to 10 days. So likewise, more than 40 kg, it's becomes adult dose, 75 milligram twice daily. And for the infants, 2 weeks to less than 1 year of age, this 3 milligram per kg twice daily. Chemoprophylaxis is not indicated, and dose would be 0.25 ml per kg is the dose. Next slide. So now moving forward the clinical trials, and these are the prospective studies. And you can see that data on lower respiratory tract infections and antibiotic use from 3,564 subjects, which age range from 13 to 97 years, influenza-like illness, and enrolled in 10 placebo-controlled double-blind trial of Oseltamivir treatment was analyzed. And in patient with Oseltamivir treatment, it's reduced chance of antibiotic use by 26.7%, as well as influenza-like illness resulting in lower respiratory tract infections in antibiotic therapy by 55% and hospitalization by 59%. So Oseltamivir is significantly reduces antibiotic use in both group and hospitalization almost 60% in this study. Next slide. So it also helps in the reducing the occurrence and severity of pneumonia due to H1N1 by early Oseltamivir administration. So a retrospective medical chart review of 442 patients was conducted, and median time from symptom onset to Oseltamivir administration was 5.0 days, and subject divided into 4 groups based on time to Oseltamivir administration. The 4 groups were less than 2 days, 3 to 7 days, 8 to 14 days, and more than 14 days. Slide. So you can see this model of the probability of occurrence of pneumonia. You can see this as solid line is probability of severe pneumonia, and dotted line is probability of any severity of pneumonia. So though both the probability of any severity of pneumonia and the probability of severe pneumonia increase gradually the time from symptom onset to Oseltamivir administration. So earlier initiation of Oseltamivir administration after symptom onset significantly reduced occurrence and severity of pneumonia and shortened hospitalization due to pandemic in H1N1 2019. So even when administered 48 hours after symptom onset, Oseltamivir shows considerably potential for reducing pneumonia. So it is better to start as early as doubt of influenza happens. Next slide. Now moving to the guideline recommendations, the WHO, we all know the authority for recommendation of, in the body. So empiric treatment is also recommended, strongly recommended. It's not also recommended, strongly recommended. And treatment should be started as soon as possible. Laboratory confirmation of influenza virus infection is not necessary for the initiation of treatment. Negative laboratory test for H1N1 does not exclude the diagnosis in all patients. Therefore, early administration is justified if in higher risk individuals have been exposed to a patient with influenza. Consider presumptive treatment with Oseltamivir. So Oseltamivir have empiric treatment as well as prophylaxis treatment. So an early empirical supportive therapy and monitoring is also important. So given antimicrobials to treat all likely pathogens causing severe acute respiratory illness, and empiric antibiotic treatment should be based on the clinical diagnosis like community-acquired pneumonia, healthcare associated pneumonia, or sepsis. So empiric therapy also includes a neuraminidase inhibitor for treatment of influenza when there is a local circulation or other risk factors, including travel history or exposure to animal influenza virus. This is the this is the older guideline, but still holds if the history of travel or history of exposure to animal influenza. We heard sometimes that bird flu is there. So in that situation, we should consider we should give early empiric neuraminidase inhibitor for the treatment of influenza. Next slide. So in adult with community chronic pneumonia who test positive for influenza, should the treatment regime include antiviral therapy? So the recommendation is that the anti-influenza treatment such as Oseltamivir we prescribe for adults with community acquired pneumonia who test positive for influenza in inpatient setting, independent of duration of illness before diagnosis. It's a strong recommendation and of moderate quality of evidence. So in adults, it is given in admitted patient also. Several observational studies suggest that treatment with oseltamivir is associated with reduced risk of death in patient hospitalized for community acquired pneumonia who test positive for influenza virus. And treatment within 2 days of symptom onset or hospitalization may result in the best outcome, although there may be benefits up to 4 or 5 days after symptom begins. So in adult, we can give up to 4 or 5 days after symptoms, but it's preferred to be given within 2 days of symptoms, as we have seen with the previous studies also. Next slide. To summarize, so proper diagnosis early treatment can prevent flu complications. Empiric use of oseltamivir reduces lower respiratory tract complications, hospitalization, and antibiotic use. WHO, American Thoracic Society, and Ministry of Health and Family Welfare recommends empiric use of oseltamivir.
Sir, coming to your experience, since how long you have been prescribing Oseltamivir?
Since COVID time, I am prescribing oseltamivir as as you said that this is after COVID, there is increased awareness about the antiviral drug. Oseltamivir is the availability is also increased. I think in COVID time, local your representatives pushed. First they have introduced the remdesivir, and then also with this oseltamivir. Since there we using many patients. So in our practice, mostly it's patient come 2 days after, 3 days after. So our experience is with the admitted patient mostly.
Correct.
In OPD, there is a tendency for self-medication also. So sometimes the patient come after 3 days, and it's not as use is not as wide as it's the influenza happens.
Sir, कभी भी patient आएगा तो when you start treatment, the patient will get benefit now, irrespective.
Yes. It's true. We have also seen in these studies
It's
also.
quite likely that with pediatrician, patient will first go to GP and then possibly come to a pediatrician.
Yes. GP or we can say this local practitioner.
Local practitioner.
Local practitioner. And I think is also noted in our practice that local practitioners, which are the paramedical or non-medical person who have worked with some clinic and practicing in the remote places, they don't use this molecule.
Yes, barabar.
So again, there is an advantage of using this molecule also.
एक बात है sir, as even doctors, we are more comfortable in using antibiotics than antivirals.
Yes, because of the
awareness about antibiotics,
awareness,
yes,
awareness as well as the confidence of diagnosing the case.
Textbook maybe antibiotics are written more than antivirals.
Yes, yes. Yes, you are right, sir.
Yes. Overall, do you think the incidence of viral infections has increased, especially after COVID?
Yes. Incidence of viral infection are increased because of the bacterial infection have
Correct.
been controlled by the wide diffusion of this vaccine in
Vaccines.
pediatrics
Correct.
is second by the hygiene also,
Ah,
where there we are and 100 times more people are about the hygiene also.
yes. After COVID, hygiene has
And
increased generally.
hygiene have increased in
Yes.
general, and the awareness or the bacterial disease
Correct.
as well as the use of vaccine.
Yes.
Mm, Vaccine is also increased.
Also increased.
And third is the more common viral also, just like rotavirus have been controlled.
Correct.
So the immune system is
Improved.
more immune system is not improved, but immune system become active against other diseases.
Yes.
So malaria has decreased. Earlier
Correct.
people have malaria and then typhoid. All these have been reduced by the after post-COVID. So the
Post-COVID.
immune system is active. मतलब as it is not exposed to the other common pathogens, then
Correct.
they take viral infection more, and moreover, there also increase exposure to the kids to the they have not started school in early age also. That
Sir,
also early age
yes.
and the
2 साल 3
moreover the
साल में आजकल
routine.
जाते हैं
हाँ,
बच्चे लोग.
दो
Yes.
साल में जाते हैं उनका
Correct.
रूटीन आप देखिए तो
Correct.
रूटीन इज हाउ दे वेक अप बिफोर इट एंड
Correct.
गो टू
Correct.
स्कूल मतलब अराउंड 8:30 8.
बड़ा बैग लेके.
हाँ हाँ, तो उनको वायरल इन्फेक्शन ज्यादा एक्सपोज होता है और जो पहले डे केयर में था या फिर एक लोकल पहले था कि बच्चे लोकल कम्युनिटी में ही खेलते थे तो उनमें
Correct.
8-10 बच्चे हुए तो उनके साथ ही इन्फेक्शन फैल सकता है,
बराबर.
लेकिन अभी 50 बच्चे हैं एक क्लास में, 40 बच्चे हैं और बच्चों का मूवमेंट भी अलग अलग लोकेलिटी से होता है बाय द अवेलेबिलिटी ऑफ ट्रांसपोर्ट. 10 किलोमीटर 12 किलोमीटर के भी बच्चे भी आते हैं. So there is an increased mixing and extra exposure of the
Exactly.
viral infection. So they are the possible reasons I could tell in this
Correct.
forum.
Sir, ऐसा होता है. So, like in COVID, the infection went from adults to children. But influenza goes from children to adults. बराबर है ना?
Yes. Influenza क्योंकि उनको बार बार होता है ना और उनका
बराबर है.
इम्यूनिटी देखिए इम्यूनिटी इज ग्रोइंग. तो
Hmm.
मैच्योर इम्यूनिटी नहीं है तो समटाइम्स दे आर एक्सपोज्ड एंड
Correct.
they develops also the symptom of this influenza.
Correct.
And the parents are in a healthy group. So
Yes.
parents are less exposed until unless they are suffering from allergy. So the children are mostly affected in this.
How soon the patient is brought to the doctor, especially pediatrician? आपने बोला है वैसे टाइम
हाँ
लगता है,
हाँ
3-4 दिन तो लगते ही है.
देखिए younger children come early,
Okay.
like one less than 3 month, 4 month. But
Correct.
older children generally their self medication is
बराबर.
मतलब widely practiced. So generally sometimes they come in 2 days, sometimes they come in more than 3 or 4 days.
Younger children must be in the high risk group, na sir, for this.
Yes. They the parents come early.
Yes.
Within 1 day also, within
Correct.
12 hours of the illness. Once the
So,
child start refusing food, they come within 2 hours also.
okay.
With
And then
so
it makes sense to start the treatment early.
yes. If there is strong doubt of influenza, we can start early treatment.
Early. Should oseltamivir be started empirically or after investigation? ये पेशेंट आते हैं तभी. कई जगह इन्वेस्टिगेशन की फैसिलिटीज होती भी नहीं है.
हाँ देखिए ये जैसा हम लोगों ने डिस्कस किया कि ओसेल्टामिविर इज एम्पिरिकली कैन बी गिवन. इट इज आल्सो recommended by various
Bodies.
international bodies
Yes.
and as well as Ministry of Health and Welfare. So we can start empirically, and if the facility of this investigation hai, we can start and then we can send, as lab is not working 24 hours.
Correct.
So the patient come in and we know that it's a rapidly progressing
Yes.
disease. So we can we can do this empirical treatment.
Yes. एम्पिरिकल ट्रीटमेंट से फायदा ही होगा.
हाँ, पेशेंट को तो फायदा, अगर मान ली किसी को हॉस्पिटल स्टे लग जाता है विदाउट ओसेल्टामिविर, तो उसका तो बहुत खर्चा हो जाएगा.
करेक्ट करेक्ट करेक्ट.
तो it can be given empirically.
What are the factors on which clinical response depends? एक तो जल्दी आना पेशेंट एक बात है.
तो first is the early start of the medicine, and second is the that intake of the medicine. If we have prescribed, if they have taken properly, children are very afraid of medicine also.
बराबर है.
So if they take medicine properly, it definitely helps.
Yes.
In outdoor, in indoor, we can so we can give by the tube and also, and they are so much sick. But in older, in OPD, outpatient, it's also depend on how the children's digest the medicine also.
बराबर है. Children are very fussy. They may refuse sometimes to take.
They may spit also.
Yeah.
Spit. It's very common in children also.
Generally, how long should be administered? आपने तो बोला है 5 days and 10 days.
At least 5 days, and if symptoms persist, we can extend. Children may shed viruses more than 7 days. So 5 to 7 days is the general consensus.
Do you prescribe antibiotics concurrently, sir?
In few cases, yes.
As the case may be. It depends on case, of course.
Case.
Yes. It would vary from case to case. But our doctors, many doctors, if they feel like prescribing antibiotics along with oseltamivir, should there be any problem, or it's okay?
It's okay. Because in some cases difficult to differentiate between
Yes.
between
especially in a GP setting, or especially in a peripheral setting where the facilities are less.
Yes.
Or how is it tolerated? Major adverse effect or contraindications?
No, there is no major adverse effect. I have seen, but so though written in literature, but we have not seen any major aspects. Only mild nausea is nausea in my practice, not other symptoms. But in literature, the other symptoms like drug allergy and these all are in the literature, not in practice actually.
Contraindication to any. Overall, your message, sir, for the audience, take home message, overall experience, take home message.
My experience is to use Oseltamivir. It's a good drug to use in OPD as well as the admitted or hospitalized patient. At least it will prevent the spread of the disease in the OPD, and in hospitalized patient, it will decrease the severity of the illness as well as the reduced use of antibiotics, and in long term, reduce use of development of antimicrobial resistance. So my take home, my message for work home, not home, it's a work message that we should use this molecule oseltamivir in OPD basis, and as the symptom of flu seasons, because it's a seasonal disease.
Correct.
So if there is a spread of influenza in community, we should use this oseltamivir in children's as young as also 2 month, 3 month also we can give this oseltamivir. So at least we should prescribe the patient and counsel the use of this medicine also, like other supportive cares.
Sir, thank you very much for sharing your experience even at this late time. Thank you very much for taking time and addressing this. I'm sure it was very interesting for the audience who attended. Very, very informative. We found some of the things very informative. Thanks once again, sir, for sharing your experience. Thanks all the doctors who took time and attended this webinar. I'm sure you must have benefited. Thanks IT team. Thanks sales and marketing team. Thanks Bhuvan. Thanks Payal for attending this. Once again, thanks, sir, and wish you a very pleasant evening and good night, sir. Thank you.
Good night. Thank you, sir. Good night.
Thank you so much.
Thank you, doctor. Thank you so much.
Thanks,
Thank you,
Bhuvan.
sir.
Thanks, Payal. Thank you.
Bye, sir.